These next two slides are optional, but I thought they might be still helpful for you because they not only fit our theme of stigma, but suggest to us some novel approaches to supporting people with mental health needs, both in the community and in as a first responder. The first one we've touched on to some extent already, and that's the psychosocial view. We spoke of psychosocial rehabilitation. This is the philosophy upon which it is founded. So it's the holistic view of mental health, the idea that in order to support a person, we need to think about them as a whole person. And we spoke about those mental health needs just a few slides ago. We have to remember always that mental health is dependent on more than one's neurology. Our neurology is the operation of our brain, just a single organ in our body, and it's connected to every other organ in our body, and our body is in turn connected to the outside world. Everything from the food we eat to the people we interact with affects the way our body works. So in order to support a person effectively, we need to take this comprehensive or holistic view, which addresses three main pillars. First, the person's physical well-being. It means we need to provide for that person in terms of things like exercise, sleep, both the amount and the schedule and regularity. We call it sleep hygiene. Nutrition, avoidance of illicit substances, full spectrum light, good hygiene, access to appropriate health care, and appropriate and effective medication. So it's not an approach that espouses not using medication. It's an approach that espouses using medication as part of a larger, more holistic view. Social well-being is the second pillar. Here we want the people to experience resilient and reciprocal relationships. Resilient mean we want relationships that are not going to constantly be breaking down, because that's very stressful for people. We want relationships that have staying power, where people can actually begin to feel some faith in the idea that they're going to be connected to others. And they need to be reciprocal relationships. Both people are giving and both people are getting. This means that we typically need to find people ways of relating with non-professionals, because when they relate to professionals only, they only are really in a taking role. Whereas if they get to relate to somebody who's a peer or a potential partner or even their children, they get to give and take. And that's something that really helps a person to feel socially valued. Emotional support must be a byproduct of some of their social relationships. They must have social value and be a social contributor, or what Adler called social interest. And it is also important for them to be spiritually connected to something. And we could have talked in this connection as well about culture. Psychological well-being is the third pillar. We need to help people resolve trauma and address major stressors in their life, for example, financial difficulties or a loss of a job. We need to help people develop a type of intelligence called emotional intelligence. And often people forget this, but the research shows that our cognitive intelligence, our school thinking, is less important than our emotional intelligence. And being able to have some amount of control or discretion over our emotions is a very important tool in terms of our coping and our mental health. We also need to have a healthy outlook on life, a realistic orientation, and a hopeful or positive orientation. We also need to have life skills and life knowledge. Literally, what are the rules of the road? What do I do to maintain my safety when I'm out in the community? How do I balance my checkbook? How do I clean my clothing? How do I take care of my hygiene? How do I get a job? These sorts of things are foundational to a person being able to feel confident and masterful in their own life and not feel as though they're constantly needing to be reliant on others. The psychosocial view fits well with our next view, which is called the gentle teaching view. The gentle teaching view was pioneered by a doctor from Canada, not a physician, but a psychologist by the name of Dr. John McGee, who passed away only in the last couple of years. Now, originally he created this idea for people who had intellectual disabilities and severe behavior problems such as violent behavior or self-injurious behavior. And he refers to the fact that he worked in institutions where people were treated with aversives. They were restrained or shocked or chemically restrained as a result of these behaviors. And he called it a culture of death. He said that basically in that environment, no person could possibly get better or feel good. And it's probably true. And certainly my experience in working with individuals, taking them out of institutions, it was difficult for me to fathom how any person could feel healthy in that setting. Now, I believe that McGee's teachings can be adapted for the mental health sector as well. In fact, much of what's done in the community living sector or services to people with intellectual disabilities is extremely transferable, and I teach it all the time in my college program. And so I really make almost no distinction in the model of approaches that we use for people with mental illness and the one we should use with people who have developmental disabilities. And we need to do whatever we can to reduce the amount of negative experiences for people in care, irrespective of why they're in care, because the reason should be fairly obvious. If people have negative experiences, they'll be alienated from seeking help, from remaining with help, and even if people are not able to physically leave, they'll emotionally disengage. They'll have less trust for the care providers. They may perhaps be in conflict with some care providers and engage in serious aggressive behaviors towards some people. And they simply will have less faith in the care that we prescribe for people, the approaches that we take, and they'll be looking to buck the care as opposed to adopt the care whenever they have the opportunity. And McGee's approach is really more about philosophy than it is about a specific technique. It's characterized by non-judgment, acceptance, and by accommodation, by recognizing that sometimes the most humane and responsible thing we can do for an individual is not only to accept them as they are, but also to recognize that we should not burden them with being the ones to make all of the change. When we're dealing with an infant, we don't criticize the baby because they need somebody to help them with feeding or with getting their diaper changed. And the same thing is true later on in life when a person declines as a result of aging. We continue to provide that person with supports because we see the humanity in the individual. Well, there are lots of examples of this. A person becomes disabled as a result of a car accident, and we give them a wheelchair and build ramps and widen the hallways and put safety bars in their home. We need to sometimes accept that people need us to meet them part way, that we need to understand that sometimes people's mental health needs are going to be sustained, that they'll need us to adapt and accept that certain things are going to be a part of our interactions with that person. And once we do that, we're often able to move forward. All things, according to McGee, begin with a sincere relationship, the idea that we see the human being and not the diagnosis. And this is a critical concept for us. It's very difficult when we're dealing with somebody who's in crisis, which is one of the more common reasons we may interact with individuals as first responders, to see past that behavior that can potentially be scary or alienating. But we need to realize that each of us has our moments when we act in a way that can be frightening or aberrant as well. And we hope that people will see us for human beings that we are. And it's important that we do the same thing. So the gentle teaching view of McGee really is, as I said, not so much about technique and about beginning with a desire to genuinely care about somebody else. And in any of the services that are being represented by people taking this course, I think it's safe to say that we can probably sum them up as human services. And isn't it interesting that in human services it's considered taboo to say that we care about the people that we're supporting. And it's particularly taboo to use a word like love. But at the end of the day, that's really what this comes down to, is that we're trying to give a little bit of who we are, what we care about, and a little bit of love to people that are out there receiving our services. Now, that may make some of you feel uncomfortable. I'm not talking about treating people like they're our friends or crossing boundaries. I am a very strong proponent for us making sure that we have healthy boundaries and that we don't try to replace unpaid, naturalized, loving relationships in people's lives. But what I am saying is, our consumers can tell when we genuinely care about them, when we're genuinely interested in their welfare, when we're genuinely interested in hearing their story and getting them forward on the goals that matter to them. And that's what McGee was saying as well. So hopefully this information has been a little bit of an additional help to you. And it's a model that I'm hoping more and more mental health practitioners discuss in their settings.